This is Pick Your Poison. I'm Dr. JP, ER doctor, toxicologist, and unapologetic lover of all things poison. Want to know what candy can kill you, even though its flavor is so beloved it was found in King Tut's tomb? And what might make camels less thirsty? Stay right here to find out. This is an interactive story. Survival isn't guaranteed. Will our patient live or die? What happens next depends on you and the choices you make. So get ready to chart your course. Today's episode starts in the emergency department. You pick up the chart of the patient in room 4. She's a 54-year-old woman complaining of high blood pressure. Looks like a pretty quick and easy complaint, and the interns and residents are busy with sick patients, so you decide to see the patient yourself and expedite her care. The patient is sitting comfortably on the bed. Her vital signs are as follows: blood pressure 190/80, temperature 98.6 or 37 Celsius, heart rate 80 beats per minute, respiratory rate 20 with 100% oxygen saturation on room air. You ask the patient what's bothering her. She says her blood pressure has been persistently high for the past week despite taking her blood pressure medicine as previously prescribed. Several weeks ago, her doctor recommended she increase the dose of her amlodipine, a calcium channel blocker, which she has done. Despite this, her blood pressure continues to be high, so she decided to come to the emergency department. You ask about associated symptoms. She reports feeling generally weak but denies other complaints including chest pain, shortness of breath, focal weakness, numbness or tingling, or change in urination. She's not had fever, cough, or flu symptoms, no vomiting or diarrhea. In fact, she denies all other complaints. She doesn't take any medicines other than the antihypertensive. She denies supplements and over-the-counter medicines, as well as tobacco, alcohol, and drugs. Question number 1. What over-the-counter medicine is the frequent culprit in elevated blood pressure? Is it A, diphenhydramine, i.e. Benadryl, B, acetaminophen, i.e. Tylenol or paracetamol, C, allergy medicine like loratadine or cetirizine, i.e. Claritin and Zyrtec, or D, decongestants like pseudoephedrine, i.e. Sudafed? The answer is D. Decongestants like Sudafed have some pathomimetic qualities and they can raise your blood pressure. This is why people with high blood pressure are advised to avoid these when they have a cold or flu, but in fact, they're a pretty common culprit in the emergency department since many people don't know. And while we're on the topic, many cough medicines contain sugar, so if you have diabetes, you should be sure to take a diabetic cough syrup to avoid elevating your blood sugar. We've talked about diphenhydramine or Benadryl causing high blood pressure in the past, but this is an overdose with anticholinergic toxicity rather than with therapeutic use. Our patient, as we said, denies any over-the-counter medicines. On exam, the patient is awake and alert, her cranial nerves are intact, her heart and lungs are clear, her abdomen is non-tender, and she's moving all of her extremities. She does seem a little weak when you examine her, but it's pretty subtle, and you probably wouldn't have noticed if she hadn't specifically complained about it. All right, so high blood pressure. This is a super common complaint in the emergency department. People get very worried about their blood pressure, which ironically makes the blood pressure even higher if they become anxious about it. That said, it's very rarely an actual emergency. We always have to explain to patients the difference between acutely high blood pressure causing end organ damage, which we would call a hypertensive emergency, and chronic hypertension. High blood pressure is technically a reading of 140/80, and the treatment goals are to get a pressure of 130/80. These goals are to prevent the risks of chronic hypertension, which I'm sure you know include heart disease, stroke, vision loss, etc. It's important to work with your primary care doctor, your cardiologist, to control the blood pressure on a daily basis. When people come to the emergency department, they're worried because they've had one or a few high blood pressure readings. It's not, however, what emergency doctors are worried about. We're worried about hypertensive emergencies. What are those? That's question number 2. Is it A, stroke, B, heart attack, C, renal failure, i.e. kidney damage, D, aneurysm rupture, or E, all of the above? The answer is E, all of the above. Hypertensive emergencies are the actual problems occurring from elevated blood pressure, whereas treatment of hypertension is about reducing the risk of these bad outcomes. Hypertensive emergencies, by definition, mean end organ damage from the high blood pressure, so damage to the brain, heart, or kidneys. The very vast majority of patients coming to the ED with an elevated blood pressure reading just need better control, i.e. adjustment of their medicines, improvement in their diet to reduce salt, etc. And oftentimes, a history and physical exam is all you need to rule out a hypertensive emergency. Sometimes you might need an EKG or some lab work. Occasionally, we do adjust antihypertensives in the ED, but I have to say most ER doctors don't love doing this because we won't, in fact, be following the patient to see if their blood pressure improves, to see if they get side effects, etc., etc. In general, we prefer to refer them back to the primary care doctor or the cardiologist managing the blood pressure to make those adjustments as an outpatient. How do we determine who's actually having a hypertensive emergency? Well, first and foremost, as I said, are symptoms. If a patient has chest pain with an elevated blood pressure, could it be a heart attack? If they have focal neurologic findings, could it be a stroke? A change in urine output could mean reduced kidney function. Blurry or double vision might mean their eyes have been affected. Sometimes a headache means a hypertensive emergency, though it's very common for patients to have headaches and an elevated blood pressure without serious pathology. Our patient is complaining of generalized weakness. This actually isn't likely related to the high blood pressure, because if we were worried about a hypertensive emergency and stroke, it would be a unilateral set of symptoms, so one-sided weakness, not overall generalized weakness. We could probably do a workup here to see if something else is happening, causing the generalized weakness. Basic labs might be useful to look for anemia and electrolyte disturbances, a urine specimen for a urinary tract infection. So you order some basic labs, a CBC, a Chem7, and a urine, thinking you'll wrap this one up pretty quickly and get back to helping the residents with the sick patients. An hour later, her results are in. The urine specimen's unremarkable. Her blood counts are normal. She doesn't have anemia. But you do find something on the Chem7 to explain the weakness. It's a low potassium. Her potassium is actually very low at 1.8 milliequivalents or millimoles per liter. Normal is 3.5 to 5. The rest of her Chem7 is normal, including her creatinine, i.e. her kidney function. All right, so you found an explanation for her weakness. Is this potassium caused by the high blood pressure? No. So what now? We need to replace the potassium. One thing you have to do first is make sure you've checked the magnesium, because potassium and magnesium are related, and if the magnesium is low, you won't have any success in repleting the potassium. You did check her magnesium and it was normal. I'd also order an EKG to check for changes in the heart related to hypokalemia. A couple minutes later, the tech hands you the EKG. You call the intern over and ask her what she thinks. She looks at it for a few minutes and then says, "What's the patient's potassium?" You smile and say, "Excellent work." She says it shows classic changes of hypokalemia or low potassium, including T-wave inversion and U waves. U waves are kind of like extra T waves, and they're classically seen in this setting. Treating low potassium, at least from an emergency department standpoint, is pretty simple. It's simple, but it isn't fast. The treatment, give the patient potassium. You can do this orally or intravenously, and most of the time we do both. Why? Because both routes have side effects limiting how much you can give at one time. Oral potassium is very irritating to the stomach, and it commonly causes nausea and vomiting. So generally, we don't give more than 40 milliequivalents at a time to limit the side effects. If you give more than 40, the patient is more likely to vomit up the potassium than absorb it. IV potassium has a different set of side effects, and that's question number 3. Can IV potassium cause A, stroke, B, a seizure, C, coma, or D, cardiac arrest? The answer is D, cardiac arrest. IV potassium has to be given very slowly because if you push it quickly, it can cause the heart to stop. When repleting potassium, we generally give only 10 milliequivalents per hour IV. We usually order 40 milliequivalents IV, meaning it takes 4 hours for the patient to get this dose. For our patient, I'd order 40 PO and 40 IV. What's causing this low potassium, did I hear you ask? Good question. First, we would think about her potassium intake, i.e., is the patient eating enough potassium? Most of us encounter plenty in our regular diets, but if she were anorexic or wasn't eating for some other reason like dementia or psychosis, then intake could be the issue. But our patient's been eating normally. The second question is the patient losing potassium? This can happen via the gastrointestinal tract with vomiting and diarrhea. The patient hasn't had this. In addition, it has to be a really copious amount of vomiting and diarrhea, not like I had a stomach virus for a few days. Diuretics or water pills definitely cause it, but she hasn't been prescribed those. Long-term steroid use like prednisone, but again, she's not taking that. The kidneys can lose potassium in certain diseases, but she doesn't have an elevated creatinine, meaning her kidney function is normal. Nothing is really jumping out at me here. Often we treat low potassium but don't get to the bottom of the cause in the emergency department. Typically, we replete it and then recommend the patient follow up as an outpatient for further investigation. You return to her room. The patient introduces you to her sister who's sitting at the bedside. You tell them the results and the plan. The patient refuses to stay, saying she needs to take care of her dogs. You tell her the potassium is dangerously low. It's already caused EKG changes, meaning it's having effects on her heart. It could be potentially life-threatening if she leaves. Her sister says she'll text a friend to take care of the dogs. After much back and forth, the patient finally agrees to stay. After she finishes the repletion, you repeat the potassium level. You frown at the computer when the level comes back. It's still 1.8. After just giving her a lot of potassium. It's hard to know exactly how much the lab test will change, but in general, we'd expect 80 milliequivalents of potassium to bring her potassium up by 0.8, meaning she'd be at about 2.5, safe enough for discharge with a few days of oral potassium until she saw her primary care doctor. But not only has it not come up to a safe level, it hasn't even budged. You scroll through her chart looking for something that might explain this problem. A shout interrupts your thought. Code blue, room 4. Uh-oh. You rush into the room, narrowly avoiding being run over by the tech with the code cart. A nurse has her fingers on the patient's neck and says, "No pulse, start CPR." You look at the monitor and see the rhythm. It's ventricular tachycardia, i.e. this is pulseless VTach. Question number 4. Is this being caused by the low potassium? A, yes. B, no. The answer is A, yes. It probably is due to the low potassium, and that's not good. The patient's sister's backed into a corner. She has a horrified look on her face. You ask her if she wants to stay or leave. She says she'll stay. What now? Well, first things first, continue CPR, get a bag valve mask to administer oxygen and rescue breaths. What about more potassium, did I hear you say? Yes, we absolutely need to give more potassium. The question is, how fast can we give it? At this point, she's already in cardiac arrest, so that concern about IV potassium is out the window. There's no formula for this, but I'd order another 20 milliequivalents of potassium and tell the nurse to give each 10 over 15 minutes. Standard ACLS protocol means we should be given epinephrine. Of course, we've talked about this many times in the past as the standard of care in cardiac arrest. Epinephrine actually drives potassium inside the cells, and it actually lowers the serum potassium. So this is a tough one. Giving epinephrine isn't going to help her potassium, the reason she's more than likely in a cardiac arrest to begin with. But withholding epinephrine during cardiac arrest also is not probably in her best interest. So what do? Well, it's a judgment call, but I'd probably give it a few minutes, do some other things to see if the VTach stops. But if it doesn't, I think you do have to give the epinephrine. The intern intubates the patient, and you tell her to put an orogastric tube in, a tube from the mouth into the stomach. You order another 40 milliequivalents of oral potassium in liquid form to go down the tube. You might try amiodarone, another antidysrhythmic that we can use to treat VFib. Unclear if it's helpful, if the cause is low potassium, but there's probably no harm in giving it. After a few minutes, fortunately, you're extremely relieved when the patient gets a pulse back. The respiratory therapist puts the patient on the ventilator, and you order another 40 milliequivalents of IV potassium. What we need at this point is a consult. I'd get nephrology on the phone stat. Not only are they some of the smartest doctors in medicine, they know a lot about electrolytes. The nephrologist says he'll be right down. He's ordered some urine electrolytes to see what's being put out into the urine versus what's in the serum. He wants an ABG for acid-base status as well as phosphate levels. After a few minutes of scrolling through the patient's chart, he says, "We need the results of these tests to be sure, but hypertension and low potassium typically means mineralocorticoid excess." What, you say? The term is vaguely familiar. You're pretty sure the last time you heard it was in medical school. Could be hyperaldosteronism, he says. You do manage to remember that aldosterone comes from the adrenal glands. It can be elevated in some congenital diseases, not likely here. Also, if you have a benign tumor in the adrenal glands, it can produce excess aldosterone. If you have narrowing of the blood vessels to the kidneys, the same thing can happen. He orders some hormone levels, including aldosterone. Some of these will take days, if not weeks, to come back. He agrees with the aggressive potassium repletion and says to get her admitted to the ICU. While she's waiting for a bed, you repeat a third potassium level. You're relieved to see it's at least increased to 2, although this is still pretty dangerously low. Not to mention she's been given a massive amount of potassium. What exactly is happening to it? You go back into the patient's room. Her sister wipes some tears from her eyes. She picks up a package of candy from the bedside and puts it into her purse, saying, "I guess I'll take these home. She won't be able to eat them now." "Wait a minute," you say. "Can I see that?" She gives you a funny look and says, "The candy?" "Sure." She passes you the package. You think you know what's happened. I know we have a lot of listeners in the Netherlands and Germany, and I bet you guys have already gotten this one. Question number 5, it's time to pick your poison. Is the candy A, candy corn, B, black licorice, C, milk chocolate, D, Swedish fish? The answer is B, black licorice. The package says Dutch licorice drops. You unfold the top and look inside, recoiling from the strong licorice smell. You don't remember much from medical school about mineralocorticoids, but you do know about black licorice toxicity. It affects the kidneys, causing low potassium, weakness, and in rare cases, even death. You rush back out to catch the nephrologist who's finishing up his consult note. You hold up the bag and he says, "You got it, that's the culprit." The medicine and emergency medicine residents circle around asking questions about how licorice caused a cardiac arrest. You're relieved when the nephrologist answers since you've forgotten the mechanism behind this fairly rare and unusual toxin. The toxic ingredient in black licorice is glycyrrhizin. Let me clarify something actually. Glycyrrhizin is found only in strong black licorice. It's not in the red licorice we have in the United States, like in Twizzlers, and even American black licorice is usually made with anise rather than high concentrations of real licorice. You can get strong types here in the US, and it's usually imported from Europe, often the Netherlands and Germany. I didn't know before this episode that there are non-alcoholic pastis-flavored drinks in France which contain high levels of glycyrrhizin and can cause toxicity with frequent consumption. That's the other important point. Toxicity occurs with very frequent, long-standing consumption, not from a few bites of licorice or a few sips of a drink. The sister says the patient has been buying expensive imported black licorice and eating several bags a day for years. How does licorice cause toxicity? Again, you're relieved the nephrologist is here to answer these questions. He says when you eat black licorice, glycyrrhizin goes inside the kidneys. It inhibits an enzyme preventing the conversion of cortisol to cortisone, resulting in cortisol accumulation to very high levels and causing something called pseudo-hyperaldosteronism. Cortisol binds to the same receptors as aldosterone, and this causes the body to think too much aldosterone is present, which in turn causes the kidneys to retain water. This results in high blood pressure. It also causes the kidneys to lose potassium, excreting it in the urine and resulting in hypokalemia. Hypertension and hypokalemia, that's exactly what our patient has. It's the reason for the refractory high blood pressure despite reasonable treatment by her primary care doctor. Symptoms can occur in as little as a few weeks to over months, and interestingly, susceptibility to glycyrrhizin varies considerably between patients. Women seem to be more sensitive than men. People who are very sensitive can be affected by 100 milligrams of glycyrrhizic acid, i.e. approximately 50 grams of licorice candy, while other people can eat 400 milligrams without a problem. What else happens? You can also see rhabdomyolysis, i.e. muscle breakdown, paralysis due to severe hypokalemia, even to the point of respiratory failure. Patients can develop renal failure. Increased blood pressure in the setting of underlying hypertension can result in hypertensive emergencies, including heart failure, hypertensive encephalopathy, i.e. altered mental status, and stroke. How much licorice is safe? It depends who you ask. The World Health Organization says less than 100 milligrams per day of glycyrrhizic acid. The Dutch Nutrition Information Bureau, though, has a limit of 200 milligrams per day. And many countries have advisories recommending avoiding it altogether if you have high blood pressure, other cardiovascular disease, chronic kidney disease, or a history of low potassium. Back to our patient. She goes up to the intensive care unit where she's treated with ongoing potassium repletion. They continue to give her liquid down the OG tube as well as intravenous potassium. Obviously, the black licorice exposure has been removed, and in a few days her potassium stabilizes to normal amounts. She's extubated and fortunately wakes up without any sequelae, including no brain damage from the cardiac arrest. Once patients stop eating black licorice, their potassium usually returns to normal over a few days to a week or so. So black licorice is a common source of exposure, but it's not the only route of toxicity. Licorice-flavored drinks, as I said earlier, can be responsible. In some cultures, people enjoy tea made from licorice root, particularly in Egypt, often during Ramadan. And the amount of glycyrrhizin in licorice root is quite high. There are several cases of toxicity from frequent consumption of homemade tea. Glycyrrhiza, the word, is derived from the ancient Greek term glycos, meaning sweet, and rhiza, meaning root. The content of glycyrrhizin in licorice root varies from 2 to 25% depending on the species. One interesting correlation I noted in several published cases of toxicity is that the patient was eating licorice to aid in smoking cessation. As a result, were ingesting large amounts in an attempt to control nicotine cravings. Licorice is a very ancient plant and has been used medicinally for almost as long. The earliest mention we have of the plant is on an Assyrian clay tablet that's dated to the 7th century BCE. As I said, it was commonly used in ancient times as medicine. It was used for things like cough and bronchitis, digestive issues. In Chinese traditional medicine, it's thought to have anti-inflammatory properties. Interestingly enough, a large amount of licorice was found in King Tut's tomb. Greek armies, including Alexander the Great, carried it along to reduce thirst. Arabs gave it to their camels as well for the same reason when crossing the desert. In modern times, licorice has been used in some unusual things other than candy. Actually, much of the American use is now in tobacco and tobacco products. It's been used in firefighting foam and insulation, as well as in compost to grow mushrooms. This is a fictional case, as are all our cases to protect the innocent. In truth, it's unlikely that the cause of this patient's electrolyte disturbance would have been discovered in the emergency department. More likely, it would have been after a lengthy workup in the ICU between the intensivist and the nephrologist. You'd likely have to wait for the results of the 24-hour urine electrolyte specimen, plasma hormone levels, etc., to get to the bottom of the case. But I wanted to speed up the timeline. All right, the last question in today's podcast is the pop culture consult. In what movie did the director have actors drink licorice-based mouthwash to turn their mouths black? A. Lord of the Rings, B. Game of Thrones, C. Gladiator, D. Dune. Follow the Twitter and Instagram feeds, both at PickPoison1 for the answer. Remember, never try anything on this podcast at home or anywhere else. Thanks for listening. It helps if you subscribe, leave reviews, and/or tell your friends. Transcripts are available at pickpoison.com. While I'm a real doctor, this podcast is fictional, meant for entertainment and educational purposes, not medical advice. If you have a medical problem, please see your primary care practitioner. Until next time, take care and stay safe.